Hi friends, we are going to discuss who should start endoscopy as well as ERCP and what are the basic steps of ERCP for that. First we are going to see some presentation for 1 minute and then we see the basic step of ERCP. So there is always a dilemma that should I start ERCP or not for the surgeon. So in such a case I feel there is a simple thing that if you are doing a surgery along with endoscopic surgery, then will be a difficult for you. The surgeon who are doing all type of surgery including laparoscopy, open, robotic surgery and plan to do ERCP, then I think it will be not a very good choice because you have already your hands are full with multiple surgeries, and this complication can occur even with the experts, and even Sachin Tendulkar can get out into the zero. So it is better to not to do ERCP rather than become a worst endoscopist or doing a bad ERCP. So if you want to start, you should have a very strong interest in hepatobiliary disease, and you should be very comfortable with upper GI endoscopy. So if you are not learning upper GI endoscopy and directly trying your hand in ERCP scope, I think that is not a very good choice. And this should be otherwise you should undergo supervised training. In endoscopy, we have seen many times you learn for 10-15 days and start doing same thing in your practice. That is also not recommended. But for ERCP, that is absolutely no. You have a very good infrastructure with ICU and anesthesia backup because complication may happen, and you have to accept the learning curve because it will take around 6 months to 1 year to learn proper ERCP. So who should not start an ERCP? If your sole interest in making a money, I don't think that this is a good choice because you are a surgeon, and there are enough surgery you have to make a money. So ERCP is not a money generating machine for you if you have enough work, and if you can't do it without mentor or training, and when you have expected a low case volume, I think if you are planning to do an ERCP 1 or 2 cases in a month, I think all that learning, your time, your energy you have spent to learn the ERCP is not worthwhile, and you have very poor infrastructure. Suppose you don't have anesthesia backup, you don't have ICU, you have a pure nursing home, then it is better to avoid. And another very most important thing in not in ERCP, in any intervention procedure, when you are unwilling to refer a case or unwilling to see that this is a difficult case and it is better not to touch this case, when you are not able to make such distinction, I think this is very no, don't start it. What is the minimum safe ERCP pathways? First, you learn yourself about upper GI endoscopy, then you see 50 to 100 ERCP, then assist cannulation, then start simple CBD stone, which is not large and small, and avoid complex anatomy. And if you failed for more than 10 minutes, better to refer. So when to stop? When you start learning cannulation more than 10 minutes, it is better to refer. Recurrent pancreatic duct cannulation, then you refer it, but try to put a PD stand. In unstable patient, difficult anatomy like along with the diverticulum, or there is a complex stones and strictures, you should avoid it. So ERCP is more a responsibility, and it is a more a training rather than talent. So those who trained adequately for proper time, it is more important than rather than talent. And reference is not a failure, man. Okay, anything complicated case, if you refer timely, this is not a failure, this is a maturity as a doctor you have, because patient safety is first most important. After this, we are going to see one ERCP and the basic steps like sphincterotomy and everything. So you do self-assessment. Should I ready to start ERCP or not? Are you confident with upper GI endoscopy? Yes. Do you have a mentor for ERCP? Yes. If you have a more than 100 cases per year, so it approximately around 8 to 10 cases per month. Yes. Do I have a fluoroscope and anesthesia backup? Yes. And first of all, I am willing to learn, I am willing to invest my time, money in this, and I am willing to refer a difficult cases in initial 4-5 years of my learning, then it is yes. If any of this answer, two or more than two answer no, then don't start ERCP. I think it is not fruitful for you. Now in next 1 minute we are going to see the basic steps of ERCP, and how we will cannulate, and how we will do a sphincterotomy, and how we will remove CBD stone and place a stent. We will continue with this various endoscopic and therapeutic cases and EUS cases, so you can enlighten yourself and you can judge the patient properly. Now let's go to the another part where we are. Hi friends, many of our surgeon colleagues are planning to start ERCP. This is the basic video for that. You have to first identify the ampulla as we are seeing in the video. Then this is the sphincterotomy and wire guided cannulation. Then wire guided cannulation is mandatory. Don't try yourself with the contrast guided cannulation. Then do sphincterotomy using Boston or any Olympus or whatever sphincterotomy you are comfortable with. Then sweep a balloon, and if, as you are seeing in this video, there are multiple CBD stone you are retrieving, and once you see that all stone has been retrieved, go for occlusion cholangiogram, and once occlusion cholangiogram is normal, you have to put a stent, either 7 French or 10 French. Just we are seeing in video. This is the basic procedure for the most common indication of ERCP, that is the CBD stone. Thank you.